So here's what I read today. One of the defining features of COVID-19 is the excessive immune response that can occur in severe cases. This burst of immune overreaction, also called a cytokine storm, damages the lungs and can be fatal. So here we have COVID-19, which is why we're home listening to these lectures, tied into the system that we're going to learn about today. So this amazing system, I hope you'll find interesting, but it is very complicated. So just hang in there and let's just go step by step learning about this amazing system. So anatomic structures and physiology of the immune system. I'm going to give you a brief overview, then we'll get into it a little bit more. So bone marrow is where white blood cells are made, specifically in the spongy part of the bone. Stem cells are capable of developing from the various WBCs and RBCs and platelets. And then our white blood cells are leukocytes. Now, see if you can remember what is the normal WBC count? 5,000 to 10,000, that's right. So if you have not enough, you can't fight off infection if you have under 5,000. If you have over 10,000, you probably have an infection. So white blood cell count is very important. Cytokines, I'm going to go through each one of the 5 types individually. So cytokines are the hormones secreted by the cells to signal other cells. Echinozoids are the fatty acids that regulate blood vessel vasodilation. The thymus gland is a lymphoid organ located in your upper chest, and early in life it makes white blood cells, and then those white blood cells turn into T cells that we have for the rest of our life. So remember, thymus, T, begins with a T, and T cells. So then we have the lymphatics, and lymph node system. Those, when blood flows through the capillary beds, it delivers oxygen and picks up carbon dioxide and some plasma that hasn't been absorbed. It's an open-ended system that dumps up into the upper chest and returns to the venous system. The lymphatic vessels prevent the lymph fluid from pooling in the periphery. Lymphatic vessels can be damaged during surgery, and individual lymph nodes can become swollen and with infection and also with some cancers. So the lymph system plays an important role in our immune system. You notice that sometimes, like in the neck, you'll feel enlarged lymph nodes, sometimes under your arms, in the groin. That is just that lymph system trying to fight off some sort of bacteria or infection. Now, the liver does like 500 things, but one of the things is it filters. Filters our cells. The spleen also filters. It filters dead red blood cells. Then we have something interesting called Peyer's patches. Those are lymphoid tissues in the small intestine. Okay, let's go through WBCs. So our WBCs, we have neutrophils, and those neutrophils fight bacterial infections. They are the most numerous of the white blood cells, comprising about 60%. But they don't last very long, maybe 6 hours. But the bone marrow is capable of producing large numbers of neutrophils to fight infections. Thank goodness. Then we've got the monocytes released from the bone marrow. They circulate for approximately a day before leaving the peripheral circulation and entering the tissues. And then they become macrophages. So macrophages clean up WBC debris, but if WBCs build up before macrophages clean them up, pus is formed, which is a classic sign of infection. So the macrophages, are the cleaner-uppers. Eosinophils, they combat parasitic infections. They also fight allergic reactions and other inflammatory processes. Then we have the basophils. They can initiate a massive inflammatory response. They release histamine. And we've talked about histamine being a major vasodilator, which makes us maybe go hypotensive, right? Which is why if we have a massive histamine release or a major allergic reaction, we could drop our blood pressure and have an allergic reaction. So we need a quick response to that. All right, mast cells, that's important to know. They store histamine and they're located in the tissues. So mast cells are located in the tissues. Okay, let's move on and talk about B cells or B lymphocytes. So B cells are like immunoglobulins, and those are antigen binding proteins. So immunoglobulins binding to antigen. Now, B cells can also be plasma cells or memory cells. Plasma cells produce a large amount of Ig. And you can see I'm going to talk about that at the end of this slide. Memory cells is a resting state. They just hang around waiting to remember something that they were exposed to before. So Ig is an antibody, and there's 4 types of antibodies. There's IgM, which is first secreted. It's your primary immune response, IgM. IgG is secreted for a secondary immune response. IgA is present in secretions such as mucus and mother's milk. IgE attaches to basophils and mast cells to release histamine. Then we have the T lymphocytes or T cells, and there's 2 types of the T cells. There's the T helper cells and C cytotoxic cells. So the CD4 cells are helper cells, and those are very important when we're fighting HIV. These secrete the cytokines or the hormones, which we talked about earlier, in response to foreign antigens. The C cytotoxic are CD8 cells, and that's a protein complex found on cell walls, and it can destroy foreign invaders. So that's basically what our immune system does, is it fights off invasion, bacteria, parasites, viruses. It's there to fight them off. So our other immune structures that I wanted to get into, the cytokines, which are hormones to signal other hormones, other cells, canasides that are fatty acids that regulate vasodilation, temperature elevation, and WC activation. Gee, that all sounds like an infection waiting to happen. Thymus gland, our WBCs mature there to T lymphocytes at puberty, and then they're released into the blood system. The lymphatic and lymph nodes, those are all part of our plasma and cells. They help rid, and I know I'm repeating myself here, but the lymphatic vessels prevent the lymph fluid from pooling in the periphery. Lymphatic vessels can be damaged during surgery, following radiation therapy, and as a result, lymph fluid can build up in the tissues, which can be like lymphedema. Lymph nodes are small patches of lymphatic tissue located along the lymphatic system. And you can actually feel these in your neck, the groin, under your armpits. And if they get enlarged, they're like fighting some sort of infection you've been exposed to. If you've noticed that when you have a cold, the lymph nodes in your neck are enlarged because they're busy fighting off that infection. All right, so the liver, among 50 other things that it does, 500 things I should say, it helps to filter microorganisms from the blood. Then there's the spleen. The spleen filters microorganisms from the blood and old red blood cells. It's one of its jobs. We have Peyer's patches, the lymphoid tissue found in the small intestine. So here's just a picture of everything. Just wanted you to see it. I know it's in your book. It's a big old picture in your book on page 556, but I do want you to see that it's important because you can see how your lymph nodes are spread out through your body, and you can see how they're an open-ended system. That right lymphatic duct kind of empties into the venous system, and you can see the thymus gland here where that is on your chest. You can see some other lymph nodes. The thoracic duct, that's pretty big, so that's going to empty waste into the venous system. There's your spleen over there on the left. Doesn't show your liver, but we know that's over on your right side. Then we've got the red bone marrow. You can see that spongy part of the bone, and that's where we make the white blood cells. So you can kind of take a look at that. I think that's pretty interesting. It really explains everything. And you can see the cervical lymph nodes. You have quite a few there, and in the armpits and in the groin. So some physiological functions that occur, important to know. So when antibodies bind to an antigen, they do not actually destroy the pathogen, but they make the antigen readily recognizable to neutrophils, monocytes, and macrophages, which can phagocytose. Now, I haven't used that word before. What does that mean? It's like Pac-Man, just gobbles it up. It gobbles up the pathogen. And so innate immunity. The way I want you to remember innate immunity, natural. It's natural immunity. You're born with it. You get it through the mother's milk. But not just that, you have it naturally. And then acquired immunity, you acquire it through being exposed to a specific antigen. So you can acquire that actively, or you make your own antibodies by repeatedly being exposed to a certain, let's say, almond blossom. And then there's passive antibodies that occurs when the antibody is produced by a person or an animal, like mother's milk. Mentioned that again. That is passive immunity, but it's also innate immunity because we're born with that. It's two separate things, even though we both are given immunities that way. A passive immunity we also get through gamma globulin. Now that's important to know because that could be an injection. That's why it's a passive passing on an antibody to you, and that could be given through an injection or from a person or an animal. And then there's cell-mediated antibodies. Those are aimed at intracellular defects, so they're in the cell, and they fight bacteria, viruses, and cancer, or transplanted tissue graft. Now, I thought tolerance was a really important word here. It seems like, oh, I could skip over that, but really, to me, tolerance is almost like a balance, right? It does not mount an immune response against itself. So it's your body not building up an immune response to itself. It's a tolerating you. And if it does get out of balance or homeostasis, then an autoimmune disease can occur if there's a breakdown in your tolerance. That makes sense now. All right, so in your book, box 31.1, it talks about age-related changes. So let's talk about that. So bone marrow becomes less productive, makes less cells. So you have less white blood cells to fight off infection, which is why the elderly are very susceptible to infections. And this COVID-19, that's why it's infecting the elderly population, because they can't fight it off like we can. Also, lymphatic tissue shrinks, resulting in fewer and smaller lymph nodes to help fight off the infections. Our immunological function is not affected unless a person is unusually stressed by a trauma. Well, who isn't, especially at that age? A chronic infection, very susceptible. A treatment for cancer. Some of them have been treated for a cancer. So those are some things that are age-related in box 31.1 on page 557. And since we do take care of the elderly, we need to know about those changes and be aware. So let's talk about the assessment. Here I'm going to really turn into your book and talk about our health history and how we want to talk to our patients. Why are they here? What do they have to say about any pertinent infections that they have? Do they bleed for a long period of time when they get cut, or do they bruise easily? Are they chronically fatigued, or do they have chronic infections, infection after infection? We want to talk about their present health and document details of anything that they talk about, their onset, severity, precipitating, aggravating factors of any kind of symptoms that they have. And also what helped those problems that they had. And we want to talk about their past health history, such as have they had cancer or prior treatment for cancer? Have they been exposed to HIV? Have they had a splenectomy, that organ that gets rid of our white blood old cells? Do they have a history of organ transplant or placement of an indwelling venous access device? Which means if they did have a device put in, then they needed some sort of either antibiotics or chemotherapy that was given to them. And then we also want to talk about any over-the-counter medications that they take, which is something we always want to talk to them about, because some of them fight medications they're already on. And in this case, in our immunological system, NSAIDs may disrupt immunologic function. So it's important to ask the patient about any recent changes in medications and any recent immunizations. Then talk about their family history. Have they had a history of cancer in their family? Did they have a death of a family member at a young age? Also, we want to do a review of their system, so we're going to do good head to toe. And that could provide us to certain disorders. Maybe they didn't tell us everything, but in our head to toe, we can find out a lot. So just a quick review of systems. Integumentary, did they have any red swollen areas? Do they have any enlarged lymph nodes? Do they complain of weakness or lethargy, restlessness, apprehension, headache? Go to their respiratory system. Have they had a cough? Are they short of breath? Go to the GI system. Any sore throat or pain when swallowing? Now, some of these things can point to other problems, but right now we're talking about the immunological system. So have they had any unplanned weight loss or weight gain? review their GI system, pain or burning with urination, or any change in their urination or blood in their stool or urine. We also want to do a functional assessment. So the thing about a functional assessment is what's their occupation and hobby. Maybe they've had exposure to chemicals or something else that would affect the bone marrow and the blood. Also, we want to talk about their diet, because is there any recent change in their appetite or weight? So we want to identify nausea, vomiting, taste changes. And there's a nutrition consideration box on this page 559. Because food contains microorganisms, patients with low white blood counts are often discouraged from eating raw fruits and vegetables and from drinking milk. However, it's not clear that this actually reduces infection in these patients, but it's important to remember that it could. Patients with HIV require high calorie and nutrient intake to combat wasting. We also want to talk about their self-concept. How do they feel about themselves? Now, if they can't work because they're sick, maybe that affects them mentally. And their loss of medical insurance could affect their health and their self-concept of themselves. Also, their activity and exercise. Can the patient climb stairs? Are they active enough, or do they get short of breath? Is it hard for them? How's their sleep? Are they sleeping okay? What's their hours of sleep per night? And can they sleep the whole night, or do they keep waking up? And then the nutrition is really important. How's their interpersonal relationships? How are they getting along with their family members? Because, stress can reduce our immune system. So we want to really talk about stress factors in the patient's well-being. Their perception of health. So how do they view themselves? Do they think they're healthy? That continuum that we learned very early in the module, that continuum of health, where do they think they fall? Are they healthy, or are they really sick, or are they somewhere in between? All right, now let's do our physical exam, and that can tell us a lot. Let's look at their skin. Inspect their skin from head to toe, and look at their color, their texture, their turgor, the temperature of their skin, skin integrity. Palpate swollen or painful areas. Be sure you check out for any bruising. And we look at their head and neck, their nose, ears, throat. Is there any enlarged lymph nodes that could indicate an infection? Are their sinuses draining? Do they have canker sores or any kind of sores in their mouth, on the outside of their mouth or the inside of their mouth? So you want to look inside as well. And then their chest, just again, looking for enlarged lymph nodes. Lungs, always listen to their lungs and document their respiratory rate and their effort. And auscultate for any wheezing, crackles, rhonchi. And that could indicate a respiratory tract infection or any abnormal breath sounds or a cough. So you really want to get a good listen to their lungs, front and back. Then their heart. Listen to their heart rate. Check out their blood pressure. And if they have an infection, maybe they're really tachycardic, because remember, infection, they could be hypotensive and tachycardic. That could indicate something to you, such as an infection. Or they could be hypovolemic, but that's why they're here. We've got to figure out what's wrong with them. So check out their abdomen. Palpate it for tenderness, listen to their bowel sounds. If you can feel their liver right up underneath their ribs, you can kind of dig underneath their rib cage to palpate the liver. You can sometimes feel the edge of the liver, and the spleen is over on the left side. You can, if it's enlarged, you'll feel it. If it's not, you probably won't feel much. Then let's get into our next thing, which is diagnostic tests and tables. So if you'll turn to table 31.1 and 31.2, it's on the next couple pages, which is 560 and 561. We're going to talk about some blood tests. But some general information about blood tests, and this is at the very top of the table. So be sure that you tell the patient what to expect when you're getting ready to take blood, or if they're having blood taken. Wear gloves for exposure to body fluids. And if they have any bleeding problems, you want to apply pressure for 1 minute, or have them bend their arm so that they don't bleed. And I'm sure you're aware that they have different blood tubes for different blood tests. So the color of the top of the tube could indicate what kind of blood test it is. So that's something that, you can always ask if somebody comes to draw the blood, what kind of tests are being done, and then you'll begin to learn the coloring of the tops of the tubes. All right, so let's talk about an ANA. So that's used to measure various blood components. Then we've got the HIV serology and virology tests. They can do blood cultures. Those are usually done like 3 blood cultures, whatever the doctor orders. They'll be drawn from different sites, right arm, left arm, between different times, could be 6 to 8 hours. Want to find out where's the infection. Sputum culture, and that's used to find out, do they have any sputum infection. You want to get a good loogie going, so get them a really good cough, and maybe they've got a colored sputum. We want to get that for a culture, get it into the container, and get that sent to the lab right away. Urine culture, that is, of course, again, to detect any infection. If you can get a midstream or a clean catch, that's good. Sometimes they already have a Foley. You can get urine specimen from the Foley catheter. Stool cultures, used to detect any kind of microorganisms in the stool. Be sure you wear gloves. Put it in a container, and that should go right away to the lab. It shouldn't be put in the fridge. You can put urine in the refrigerator, but not stool. It has to be kept warm. Then under some diagnostic tests, let's go to the next page. Oh, I can't go back, but let's talk about the next page first. So lymphadenography, the thing here, all right, is that if they're going to have a test and they're given a dye, what's the question you need to ask them? Are they allergic to shellfish? So that's really important if they're going to have any kind of scan. And if it's a nuclear scan, that means they're given some dye. So you want to ask if they're allergic to anything, any kind of shellfish. Another thing that's important on this page here before we move on is a CT scan. So a CT scan, again, might get dye. They can just do, the CT scan usually includes the liver. So that will tell if there's any abnormalities in the liver. And encourage fluids after dye to promote excretion of the dye, and watch for delayed reaction to the dye for 2 to 6 hours. So they might not have it immediately, but they might have it a little bit later. So keep an eye for dyspnea or rash, tachycardia, or hives. Let the doctor know. It can be treated with steroids or antihistamines. A PET scan is something that is done sometimes, reveals lymphoma. And then some skin tests can be done to detect allergies, TB tests. They're done intradermal. So, okay, let's go to the question here we have. You've been looking at it for a while, so you bet you know the answer already. So, which of the following is a true statement? So, the answer is B. The thymus is a lymphoid organ located in the upper chest below the thyroid. And early in life, certain white blood cells called lymphocytes migrate from the bone marrow, where they're produced to the thymus, and there they mature. So T lymphocytes are T cells, or mature T lymphocytes, released into the circulation. After puberty, the T cell population has been maximized, and the thymus stops growing and eventually shrinks because it is no longer needed. So that was a long answer for just B, wasn't it? All right, well, you had a long time to look at it, so I had to give you a little extra information. All right, let's go to question number 2. Which of the following statements are true about white blood cells? So let's look at that. Which of the following statements are true about white blood cells, WBCs? So the right answer is B. Macrophages can ingest many foreign antigens and survive months to years. Oops, sorry, I went ahead. Sorry. All right, let's move on then. All right. So now let's go to table 31.3, where we talk a little bit about some blood tests. And we'll talk about some drug therapy. 31.3. One's box and one's a table. So box 31.3 just points out your complete blood count and all the normals. And then your differential, where you see your lymphocytes, monocytes, neutrophils, eosinophils, basophils. All right, let's go over to the drug therapy table. Drugs used to treat immunological disorders. So you've got your corticosteroids, prednisone, oral parenteral, intranasal, topical. They can put on joints. Not really sure here too much that's important, but they're powerful drugs with many adverse effects. So when you have a patient receiving any of them, use your drug handbook for more complete information. You will see that these drugs suppress the immune system, so you can anticipate a risk of anemia, thrombocytopenia, and leukopenia. Now I just want to go back here to the blood cell, blood test. So normal WBC counts, as I said, from 5 to 10,000, and the majority of the WBCs are neutrophils. And neutrophils are the cells that fight bacterial infections. Other blood tests are specific to the diagnosis of a particular disease, like the ANA detects antibodies in the blood that can be indicative of lupus, that's SLE, or other autoimmune disorders. HIV testing, the CDC classified these as nucleic acid tests, or NATs. It used to be, in old days, we couldn't even be told or tell anyone that a patient had an HIV test. Now, it's more accepted, more known about. There's even home tests and that can be done. But remember, next chapter we're going to talk a lot about HIV. But the virus is undetectable immediately after infection. So that's why HIV testing isn't always great. Viral load HIV is not a screening test. The amount of HIV present in the blood of an infected patient provides information about the progression of the disease. And then I want to talk a little bit about the cultures. They detect infections, we know that. Skin tests can point out hypersensitivities. And all right, let's talk about organ transplant. I know that's not next that's listed here, but it is next in your book. So organ transplant. You can transplant a kidney, heart, liver, or other organ or tissues. And there is an allograft, which is a transplanted organ or tissue. Rejection can be seen. So they have to take special medication to prevent rejection. Hyperacute rejection occurs within 24 hours after transplant, requires removal of the transplanted organ, which could be bad if it was a heart, because they need the heart. It is caused by pre-existing antibodies. Acute rejection occurs within 6 months. A lot of times when they have a patient that has a transplant, they keep them close to the hospital, specifically for this kind of reason. So if they have a transplant in another state, they'll have to live in that state for about 6 months. Acute rejection occurs within 6 months after transplant and can usually be reversed with immunosuppressant drugs. Chronic rejection occurs months or years after transplant. So they do monitor them yearly, sometimes 6 months to a year, just to look for any symptoms that they're beginning to reject that organ. Large numbers of T and B cells infiltrate the transplanted tissue, causing fibrosis and scarring, and then it's slowly rejected. It's important to match the tissues of the donor to the recipient to maximize the fact that it will take, or they can keep it and not reject it. The drugs, though, suppress the patient's ability to fight infection, so they have to watch where they go, what they're exposed to. They might have to wear a mask. They'll be on combinations of steroid drugs, methotrexate, cyclosporin, some other medications that suppress the immune system after an organ transplant. So now we can go to hematopoietic stem cell transplant. So I have here that the major complication is infection. Well, that's important to remember. So let's talk about just the cell transplantation first. It's a life-saving treatment for patients with a variety of types of cancers and non-malignant conditions like aplastic anemia. Maybe they just need their bone marrow replaced. Allogenic bone marrow transplant requires a donor whose human leukocyte antigens match those of the patient, so they're like the perfect match. And stem cells are transfused. Then there's synogenic bone marrow transplant, where it's identical twin, and they're usually a perfect match. Then there's autologous bone marrow transplant, a best option for patients with a solid tumor that is not metastasized to the bone marrow. Now, the third type of transplant is peripheral blood stem cell transplant. That seems to be the most common. So what they do is they do apheresis. So it's like dialysis. They put a large bore catheter into the subclavian vein, and they withdraw the blood and then reinfuse it. But while they're doing that, they have it going through an apheresis machine. So it centrifuges the blood and separates the white blood cells, the red blood cells, and the plasma, and the stem cells. When enough of the peripheral blood stem cells are harvested and stored, the patient is treated with chemotherapy, so their bone marrow is suppressed, and radiation therapy as well. and then they can get their peripheral blood stem cells returned to them. And since it's their own, right, then they're more apt to accept that. So I want you to remember this again. Major complications of bone marrow transplantation and peripheral blood stem cell transplant is infection. Also thrombocytopenia, renal insufficiency, hepatic veno-occlusive disease, but infection is the main concern. For about 2 weeks after the transplant, the new bone marrow is re-engrafting, and the patient can become severely neutropenic. So they're drawing their blood, watching their white blood count, and all the neutrophils, basophils, all the other cells to see if they're coming back. Renal insufficiency can occur if the kidneys are damaged with high doses of nephrotoxic drugs. So they're watching the renal function as well. Hepatic veno-occlusive disease can occur if the liver is damaged with high doses of chemotherapy. So you can see it's a very fragile dance that they have to do. They have to try to get the medication to the patient, but balance that with not damaging them too much with medication. Then there's a graft versus host disease, a complication of allogenic bone marrow transplants, where the T cells in the transplanted bone marrow identify the patient's tissue as foreign and try to destroy the patient's tissues. Patients undergoing bone marrow transplant or peripheral blood stem cell transplant as treatment for a hematologic or immunologic system disorder are frequently hospitalized, and they're in a special transplant unit with a special room. Now let's look at the nursing actions that you need to take. So that's in box 31.4. The next one. So the patient should have a private room, so they're not exposed to anybody else. A compromised host precaution sign should be put up at the door. All persons entering the room must wash their hands before touching the patient for any reason. Monitor the patient's vital signs every 2 to 4 hours and notify the physician immediately if the temperature goes up. Invasive procedures should be kept to a minimum. Careful attention to aseptic technique because they're so fragile and susceptible to infection. Designate a particular stethoscope and thermometer to keep them in the room for that patient. Masks are not required. In fact, they're discouraged. Staff with upper respiratory tract or other infections should not even care for that patient. Clean tabletops, equipment, and the floor frequently with hospital-approved disinfectant. The patient should be taught also to wash his or her hands, before and after eating, using the toilet, or doing any other self-care. Liquid soap instead of bar soap. Bar soap can hold bacteria. Encourage the patient to cough and deep breathe every 4 hours because we don't want pneumonia. Smoking should be discouraged. Only canned or cooked foods may be served. No raw fruits or vegetables because there's a risk that they could have an infection like E. coli, Pseudomonas, Klebsiella, or other food-related infections. The diet roster should be noted, even from the dietary, that this is a compromised host, so precautions should be taken. Maybe just plastic silverware, not the metal that needs to be returned or given to them, because what if they didn't get washed correctly? Tests, scans, and appointments away from the patient's room should be coordinated in advance to eliminate wasting time in common waiting areas. The patient should wear a clean mask when outside the room, and a new mask should be used for each time they leave the room. Some hospitals allow flowers and plants in the patient's room. However, the patient can't touch them because we know they can carry bacteria. So it's better just not even to let them in the room. No humidifiers with standing water should be used in the patient's room. Teach the patient and family about the underlying pathophysiology that puts the patient at risk for infection and about precautions to minimize the risk for infection. A lot of families want to bring in food, especially if the patient's not eating well, but that has to be discouraged because unless they are aware and take specific precautions in washing and cleaning the food.